Thank you all for coming. I'll try to move past this somber note to a more uplifting note to the extent we can. Thank you all for joining us. We're going to go ahead and begin. I know some more folks are coming in from the outside, and we'll just go ahead while they come in. I want to begin with a few things. First, to all of you, while you're eating, please complete the pre-symposium questionnaire at this time. So if you could open the thing that's in front of you, there's a questionnaire that you have to fill out before we start. We'd love you to do it now. And then what's going to happen is our staff is going to come around and collect it. And you can fill it out while I'm talking, so which I know you all do at work anyway. Staff members are walking around the room. They're collecting them before we begin the program. And I'll do some housekeeping bits while you're filling that out. I'd like to thank Vox Media for sponsoring this program. I'd like to thank Chiesi USA for providing an educational grant that supports this. So if you all want to take a moment to go to that booth and thank them for sponsoring, for being a sponsor at NCS and for this program, that'd be great. To receive credits afterwards, please complete the evaluation form afterwards and return it to the staff at the end. So you're going to do a pre-symposium one now, and then at the end, you'll also fill out a bunch of questions and turn that in. Just so you know, that's not just to give you credits. It's super helpful for us to know what was good, what worked out well, what didn't work out well. We really appreciate it. There are faculty disclosures. They're all in the handout. There's representative slides in the handout, so you can feel free to take notes, but if you don't, that's fine. You've got the slides with you. The presentations are also going to be available later on Medscape, so you can see them there. We have question cards on the tables. If you want to ask questions, you can just fill that out, and personnel will be going around collecting question cards, and so we can answer questions up here. To be aware of future programming, you can follow at CME Planet on X, and formerly known as Twitter, and other social media sites. All your electronic devices, please turn them to silent mode for this program. We'd really appreciate that. I'm going to go ahead and just begin by introducing our panel members. My name is Josh Goldstein. I'm a professor of emergency medicine at Harvard Medical School. I am vice chair of faculty affairs at Mass General Hospital and Brigham and Women's Hospital, both in Boston. Our faculty include Dr. Alejandro Robinstein. He's the professor of neurology at Mayo Clinic in Rochester. We have Dr. Adnan Qureshi, a professor of neurology at the University of Missouri Columbia School of Medicine in Columbia, Missouri. We have Dr. Dawn Mathern-Meyer, who's a professor in the Department of Neuroscience at UC San Diego in La Jolla. Thank you all for joining us for this conference today. All right. So here's the disclosures, and we'll go ahead and begin with our first, Dr. Robinstein. Thank you so much.
Thank you. So my talk, and sorry if I have to go fast because we only have 15 minutes, I'll start talking about acute ischemic stroke. The entire theme of this hour is going to be blood pressure management. I'll refer exclusively to ischemic stroke for the next 15 minutes. These are my disclosures and the learning objectives. And let me start by discussing the rationale of why lowering blood pressure after acute ischemic stroke makes not much sense. The benefits would be to reduce the risk of reperfusion injury and hemorrhage. That's the main thing. You can also say if the hypertension is really very severe to prevent systemic complications of hypertension. On the other side, the main risk is to further compromise areas that are hypoperfused, areas of ischemic penumbra, and to a lesser degree, you could say theoretically you can diminish the washout of a small distal emboli if you lower the blood pressure and reduce the forward pressure in the circulation. And you can also cause hypoperfusion or even ischemia in other organs such as the kidneys. When determining whether I am going to decrease the blood pressure or not in a patient with an acute ischemic stroke, there are several factors to consider. Mostly the setting, where is the patient in the pre-hospital setting, emergency department, for those that have large vessel occlusion in the angio suite, and then in the stroke unit or the ICU. And the other thing is what is the reperfusion status of the patient? Is that a patient that is still occluded? Is the patient about to receive or receiving a chemical reperfusion, intravenous thrombolysis, or is the patient a candidate for mechanical thrombectomy? So I'll go following the clinical course of the patient, starting by the pre-hospital setting. And I want to mention two studies. The Interact4 trial that will also be mentioned in the ICH talk. It enrolled over 2,400 patients in China to two arms in the pre-hospital setting in the ambulance before getting to the emergency department, either the usual care or dropping the blood pressure to between 130 and 140 systolic within 2 hours of onset of a presumed stroke. That meant that there were patients with ischemia and with hemorrhage. Slightly over half of the patients had ischemia. If the trial had been conducted in the United States, the number would have been much higher. And those with ischemia had an increased risk of poor functional outcome if they had been randomized to the pre-hospital blood pressure reduction. The entire trial was neutral. We're going to see that it was beneficial for ICH, but it was clearly detrimental for patients who had ischemia. Then the RIDE-2 trial was also a pre-hospital study, this time randomizing patients to transdermal glyceryl trinitrate or sham therapy within 4 hours of presumed stroke onset. Over 1,000 patients, 60% or so had ischemia. And in this case, the reduction in blood pressure was just modest, and there were no differences in functional outcome, which leads me to conclude that either it can be not beneficial if the blood pressure reduction is modest, or detrimental to lower the blood pressure blindly in the pre-hospital setting, and the patient ends up with ischemic stroke. Once the patient is in the ED, it all depends, as we know, on whether the patient is going to be a candidate for some form of reperfusion therapy or not. If the patient is not a candidate for reperfusion therapy, the traditional recommendation is to allow for substantial permissive hypertension before deciding to reduce the blood pressure. The usual values recommended in the last AHA guidelines is 220/120, and that has been the recommendation for quite some time. But be aware, this is completely based on expert opinion. There is fairly limited evidence comparing different targets of blood pressure reduction in patients who are not recanalized. For IV thrombolysis, the recommendation for the longest time since the 1990s has been to lower the blood pressure if it is greater than 185/110. And this comes from the original NINDS trial for IV alteplase. And it was an operational decision to put that target, and it has never until recently been tested. And extrapolating from that, the same recommendation was used for mechanical thrombectomy, because that is the way that it was that the trials, the seminal trials of endovascular therapy for large vessel occlusion were conducted using the same blood pressure targets. However, there was a study that, although observational, I think is interesting, was published in Lancet Neurology last year. It was the TRUTH study conducted in the Netherlands. Essentially, centers that follow the usual recommendations of blood pressure reduction versus others that were rebels, that were already going rogue and not lowering the blood pressure. And they decided to check which one was doing better for patients. And actually, the ones, the centers that were not reducing blood pressure had better outcomes than the patients that follow this long-standing recommendation of reduction of blood pressure to below 180/110 before IV lysis. Once the patient is in the, so let me go back and say, I think that this is a question that deserves to be tested in a randomized controlled trial. So in the angio suite, and even after the angio suite, in patients who have who are candidates for endovascular therapy. Several trials have been conducted testing more or less aggressive blood pressure reduction within the first 24 up to 72 hours after successful recanalization. And they include the BP Target, Enchanted 2MT, Optimal BP, and Best 2 trials. And the references are there. And I will, since all the trials pretty much show the same thing, I will refer directly to a meta-analysis. But let me point out that there have been no randomized controlled trials on intra-procedural blood pressure management, what to do before you know whether the patient is going to be recanalized or not, while the patient is still occluded. And there have been no trials on patients who do not have successful recanalization. So that those are knowledge gaps that we still have. When you take those 4 trials that I mentioned in patients who are successfully recanalized, you end up with nearly 1,600 patients, and consistently there were lower rates of functional independence at 90 days in the patients randomized to the intensive blood pressure control arms. Although there were no differences in 90-day mortality, symptomatic ICH or hypotensive events. Actually, the fact that that symptomatic ICH was not reduced by the intensive blood pressure arm it also indicates that that is a strategy that is best not to follow. So, based on current evidence, it is better to treat hypertension after successful mechanical thrombectomy only if the blood pressure is greater than 180. Here you have the numbers of one of several meta-analyses that have been conducted. Yeah, I chose this one because I'm a co-author, but I think it's fairly well conducted, and in any case, they all show the same thing, and it is what I mentioned before. Rates of functional independence are lower in those patients that were randomized to the intensive blood pressure reduction, no differences in intracranial hemorrhage. Now, why this may be? Why is that that blood pressure reduction may be detrimental? And the theories are that one is that in those patients who have the so-called no reflow phenomenon, so you open the blood, the major occluded blood vessel, but you don't get full reperfusion in the territory, although on the angiogram you see it as a TK2B, looks pretty good, but there may be clamping of red blood cells, of leukocytes. That no reflow phenomenon that is well known in experimental settings may be one of the reasons. You lower the blood pressure, you make that situation worse. And I think much more importantly, or at least as important, is that in patients who have preservation of autoregulation, the blood pressure spontaneously declines after reperfusion. So if you use a lower blood pressure target generically, regardless of the state of autoregulation, the magnitude of reduction is going to be greater precisely in those who have worse autoregulation. So the patients that stay up get reduced more, and that degree of blood pressure reduction leads to greater blood pressure variability. And blood pressure variability is a concept that I'm interested in and is increasingly receiving more attention because greater blood pressure variability has been associated with worse outcomes, worse functional outcomes in acute ischemic stroke and actually in intracerebral hemorrhage, in subarachnoid hemorrhage. And there are studies in acute ischemic stroke that show us that, and also that the time below systolic blood pressure less than 100 or above 190 increases the odds of poor functional outcome. So reducing the blood pressure too quickly and too deeply can be problematic. The same way that, that not reducing the blood pressure in patients who have a blood pressure that is really very high may also be problematic. So we need more information, but the concept of blood pressure variability deserves to be taken into account, and that has to be taken into consideration when deciding what drug to use acutely. I personally prefer to use rapidly titratable agents if with good nursing that have a rapid on and off effect, so I can maintain the blood pressure under a tight degree of control. And I think that that can be achieved better with intravenous infusions of calcium channel blockers. Yes, I happen to use clevidipine, but I think that clevidipine and nicardipine should be tested head-to-head in a controlled fashion. So, for the sake of time, let me conclude by saying, one, pre-hospital blood pressure reduction in patients with acute ischemic stroke is not useful and actually can be detrimental. The traditional strategy of blood pressure reduction before intravenous thrombolysis, I think that needs to be re-examined. Aggressive blood pressure reduction after mechanical recapitalization based on available evidence from 4 randomized controlled trials is not only not beneficial, but can be detrimental. And at this point, the better thing to do is to treat the hypertension only if the systolic is over 180 after successful reperfusion. And finally, think of blood pressure variability, the rapidity and the depth and magnitude of blood pressure reduction when considering what blood pressure to target, and consider the state of reperfusion, the state of the collateral flow when deciding how much to lower the blood pressure and what antihypertensive agent to use. And with that, I stop here. Thank you.
I'll just say real briefly, we're going to do questions at the end. Please feel free to write questions on the thing, and our staff will collect them. Also, if you just came in, please fill out your pre-assessment now, and so our folks can get that. Our next speaker will be Dr. Adnan Qureshi, talking about blood pressure control in ICH.
Well, thank you so much for having me here. It's always difficult to take the podium after somebody who writes the guidelines taking precedence to you, but I'll try my best. So blood pressure control in patients with intracerebral hemorrhage. These are my disclosures. So in the most recent guidelines on intracerebral hemorrhage, there are 2 new things that you will be seeing. We've already, in the previous guidelines, blood pressure reduction to a target of a systolic blood pressure around 140 millimeter of mercury was already there. But in 2022, essentially there is some new statements that have gone in there. One is actually an emphasis on continuous smooth and sustained control and avoiding peaks and large variability. And the second thing is the time factor. So essentially previous guidelines never specified how fast you can achieve the blood pressure goals. In the new guidelines, it actually is 1 hour. So within 1 hour of initiating the treatment, you have to achieve these goals. So that is actually the new things that we actually have in the guidelines. And essentially, it actually tells you the quality of evidence behind that. So obviously, the smooth and sustained control is really not backed by randomized clinical trials, because no randomized clinical trial to date actually has evaluated that parameter. Essentially, the time factor is there. So you need to achieve the blood pressure goals within 2 hours of symptom onset, or preferably arrival, but within 1 hour of actually initiating the treatment. So it's a pretty aggressive treatment goal. And the blood pressure goals actually are pretty similar. So it's really keeping the blood pressure between systolic blood pressure between 130 and 150 millimeter of mercury, and then really roughly achieving the goal to around 140 millimeter of mercury. I think the guidelines do actually mention that there is certain patient categories where you really don't have enough data. So patients who have large intracerebral hemorrhages, those undergoing surgical evacuation, Those were patients that were not included in the ATAC2 and INTERACT2, so we really don't have any data. And then there is this interesting category of patients who actually come in with a systolic blood pressure more than 220 millimeter of mercury. So all the guidelines really applied to patients coming with a systolic blood pressure between 150 to 220 millimeter of mercury. But if you come with a more excessive blood pressure, where blood pressure reduction would have to be of a larger magnitude to achieve the goals specified in the guidelines, essentially there's a word of caution that blood pressure reduction in such patients or rapid blood pressure reduction may actually be detrimental. So essentially some additional recommendations and a new cautionary guideline that in patients who come with systolic blood pressure more than 220 millimeter of mercury, aggressive blood pressure reduction may actually be detrimental. So, we talked about blood pressure variability. And, historically, if you look at when the first blood pressure was measured, and that's like in 1733, there were two things that were described: the absolute value of blood pressure and the blood pressure variability. And in the next 200 years, everybody keeps talking about the absolute value of the blood pressure, and what people have forgotten is the original description of the variability. But now there is new data coming in that blood pressure variability itself may be detrimental in patients with intracerebral hemorrhage. And I think the Be Precise consortia tried to address that blood pressure variability, so essentially gave more definitions than actually strategies, and tried to define two separate time frames. So there is a time frame when you're aggressively trying to reduce blood pressure to achieve your goals, and it's called phase 1, or the landing phase. And the second is the maintenance. So once you've achieved your goal, you want to keep the blood pressure in the same range, so the plateau phase. So I think that we are probably trying to characterize blood pressure variability before we can even address how best to treat it. The other thing I just wanted to point out is that the meaning of blood pressure variability in intracerebral hemorrhage. So if you look at all the publications, they will say, yes, blood pressure variability leads to a higher rate of death and disability in patients with intracerebral hemorrhage. But that is actually a time-dependent effect. The blood pressure variability is not the same prognostic value throughout the first 24 hours. And actually in the ATAC2 trial, if you do a post-hoc analysis, and this publication is going to be coming out in the next 2 weeks, essentially if you look at the blood pressure variability for the first 24 hours and try to determine, is there a time frame where blood pressure variability has the most negative effect? And looking at various outcomes. And this graph actually shows you that if you take the patients who actually had death or disability at 90 days and compare it to patients who had good functional outcome at 90 days, and look at the blood pressure variability as a function of time in this graph, you can see the graph really differs in the first few hours. So patients who actually have a higher rate of death and disability have more variability, but in the early part, and afterward, the blood pressure variability between the two groups is the same. So there's almost a concept of time window for blood pressure variability as well, in terms of monitoring and in terms of actually treating blood pressure variability. So it's a time-dependent effect. So the earlier you can initiate treatment to dampen the blood pressure variability, the potential benefit is really there. And that actually is true for any outcome. So if you look at blood pressure variability on every hour, so you're looking at every hour blood pressure variability as a predictor, and it's the same. So essentially, even with hematoma expansion, it's a time-dependent effect. With neurological deterioration, it's the strongest association. So blood pressure variability has the strongest predictability for neurological deterioration in the first 24 hours, and perhaps not so much an effect on acute kidney injury. So now we have this information. You want to reduce blood pressure, but you want to avoid variability. But you can't really write that in an order set. You can't write an order, reduce blood pressure, avoid variability. It's going to be so confusing and so non-specific. How do you interpret it? So you have to come up with some treatment way that you can actually mention or create a treatment goal. So there is actually a new definition. It's called blood pressure reduction variability, blood pressure reduction with stability as a new therapeutic target. Actually, that term was actually coined by Alexandro, so I have full credit there. And it actually looks at reducing blood pressure, but actually maintaining the blood pressure in the treatment goal. So essentially what the translates into is you're saying reduce blood pressure to a value of 130 to 150 millimeter mercury, but maintain it in the same range for the next two readings. And only then you have achieved your therapeutic goal. If you reduce blood pressure and the blood pressure actually went below 130 or went above 150 in the next recording, that's not a therapeutic success. So we actually combined the data from INTERACT-2 and ATAC-2 to see that how frequent is it that you truly achieve blood pressure reduction with stability. We've already published data on blood pressure reduction in each individual trial. So what that means is you came in with a blood pressure between 150 and 220 millimeter of mercury. After initiating treatment, for the next two recordings, were you in between 130 and 150 millimeter of mercury. So if you look at it, you say, that sounds like a reasonably easy goal to achieve. But actually not. So in this 3,600 patients, combined both trials together, and remember, a highly selected group of patients with intracerebral hemorrhage, standardized blood pressure reduction treatment protocols, and only 28.7% of the patients achieved the goal within 1 hour and maintained the goal. So even today, in the best case scenario, 70% of the patients are not achieving the goal in terms of systolic blood pressure reduction with stability. And the question is, yes, whether that actually is a goal, whether it truly correlates with clinical outcomes. And it actually does. So patients who actually have or achieve systolic blood pressure reduction with stability have a significantly lower rate of death and disability at 90 days, have a significantly lower rate of neurological deterioration, and even hematoma. The only effect it did not have was on hematoma expansion. So blood pressure reduction with stability, one, there is a lot of margin for us to improve on, and secondly, it does actually have prognostic significance in terms of patient outcomes. And even after adjusting for all the other covariates, so take away the effect of age, take away the effect of hematoma volume, take away the effect of intraventricular hemorrhage, even then systolic blood pressure reduction with stability actually predicts independent functional status, a modified Rankin scale of 0 to 2 at 90 days. So the last thing actually we want to talk about is that now we have a treatment goal. How do we actually incorporate this treatment goal in a clinical trial? So we have the clevedapine for the antihypertensive treatment of acute intracerebral hemorrhage, or the CLUTCH trial. And the CLUTCH trial actually made it a primary endpoint. So we said that patients who actually receive intravenous clevedapine as compared to an alternate intravenous agent, what proportion of patients actually achieve systolic blood pressure reduction with stability within 1 hour of treatment initiation. So the primary endpoint really is defined that you actually start the treatment, you lower the blood pressure to a value between 110 and 150 milliliter mercury, but there's two successive recordings that you need to take 15 minutes apart, and the next recording also have to be in that range. And only then you have a therapeutic success. And the trial is actually comparing two different agents. So really in the United States, a comparison between intravenous clevedapine and intravenous nicardipine, because those are the two medications that are being used for treatment of blood pressure in intracerebral hemorrhage. And the treatment goals are consistent with American Heart Association, American Stroke Association guidelines. But this is actually a schematic that actually kind of presents the difference in determining a therapeutic success. In scenario one, you reduce the blood pressure, and you kept the blood pressure for the next two consecutive recordings within the range. So yes, that is the time that you've achieved a therapeutic success. But scenario two, you actually did achieve the blood pressure reduction, but the next recording was below the therapy range, the next recording was above the range, and it's only after a few hours you actually achieve 3 consecutive recordings that are actually in the therapeutic range. So essentially, the time to reach therapeutic success will be when you have actually achieved the 3 consecutive recordings. So there is actually a continuous variable, a time to achieve therapeutic success defined by more than just blood pressure reduction. And essentially, it will be comparing the patients who get treated with intravenous nicardipine and those treated with intravenous clevedapine, and see how many patients actually achieve the primary endpoint, which is systolic blood pressure reduction with stability, and also the time to reach. So on one hand, you're looking at how many reach, or the proportion of patients that reach systolic blood pressure reduction stability within 1 hour of treatment initiation. And also the other variable is the time to actually achieve systolic blood pressure reduction with stability between the two groups. So in the interest of time, I'm actually going to conclude here. Systolic blood pressure variation or variability appears to be a therapeutic target in patients with stroke, but particularly intracerebral hemorrhage. But we still have to define what is the best strategy to reduce systolic blood pressure variability. We still have to identify that strategy. And then the practicality of the therapeutic endpoint, early institution, and integration with overall care plan will be the key to success. Thank you.
Dr. Qureshi, thank you so much. Actually, for our next piece, again, I'll take a moment, say if you have any questions, write them down, we'll collect them, and we'll answer them at the end. We'd love to have Dr. Robinstein come up and present a case to us for a little bit of discussion amongst our panelists.
Okay. So, I'm going to present a case on a patient that I saw last month, and use it as an illustration for a discussion on what to do in a typical case of mechanical thrombectomy. This was a 48-year-old woman, unfortunately with recent diagnosis of ovarian cancer, still untreated, presented with the left MCA syndrome, only 2 hours after symptom onset, very severe left hemispheric syndrome with an NIHSS of 18. She was acutely hypertensive with a systolic of 188, but did not have any history of hypertension and had no laboratory or historical contraindications for IV lysis. This was the head CT, essentially an aspects of 10 and remarkable. This was the CTA with the clear left M1 occlusion. So the question to the panel is, how should we treat this blood pressure? What should be the goal? How fast should we get to that goal? Are any risks in treating the acute hypertension, and what drugs should be used?
Maybe I'll begin with maybe Dr. Meyer.
Sure. So, what is the goal blood pressure? So you haven't given me a reason yet why she's not eligible for thrombolysis. You said she had no
She
contraindication. So that's, of course, what we're thinking first when this patient arrives, because she's within that treatment time window. So our goal ultimately is our thrombolysis goal, so 185 over 110. However, she's just slightly outside of that range. So the pragmatic approach to this is to check the blood pressure again.
So I think that there is something interesting in the image that you showed before. If you look at the middle cerebral artery, there is actually some of the branches of middle cerebral artery are actually filling through collaterals. So while on one hand you could argue that you're lowering blood pressure with the aim to prevent a post-thrombolysis, post-thrombectomy intracerebral hemorrhage, but on the other hand you could argue that if these collaterals are truly blood pressure dependent, and essentially lowering blood pressure would actually impair the flow into these collaterals, an argument could be made that perhaps not be aggressive at all.
Sounds good. I would say from my end, I think one of the key things is, especially when all this is happening super fast, and one of the key problems is we really want the nurses and the pharmacists and the residents all everybody agrees on what we're doing, and we all know it. And so I would probably go with, we have a rule, they're a thrombolytic candidate, this is what we do, and we sort of do that, and we're thinking in parallel, but we're doing the same thing everybody sort of knows how to do.
So what we did was to recheck the blood pressure,
They must have
and it was right below, which made me very happy. So we gave IV tenecteplase and took the patient immediately to the angio suite. On arrival to the angio suite, the blood pressure stayed high in the 170s over 90s to 100s. So here we are. What happens if the patient needs to be induced for intubation? Even without that, where do we keep the blood pressure? When do we lower it? Do we ever augment it? And what drugs should we use if the blood pressure is not within the threshold that we have considered acceptable or ideal?
I'll start again.
Start
So I know in our institution, we try to avoid intubation because of all of the downstream consequences of that, including reduction of blood pressure when this person probably does need a higher cerebral perfusion. So if it can be avoided, we would avoid it. However, if you do have to intubate that patient, I would let the anesthesia team know this is a patient I want to keep on the higher side because I know that occlusion is there, and I know that I want to get as much perfusion past that occlusion that I can if there is any chance of that at all. I don't generally recommend augmenting the blood pressure with things like pressors, because I think what some people don't consider, again, in those downstream consequences, is pressors can sometimes also activate platelet aggregation. You've got a person that's already got a clot, and we don't want to add that additional aggregation factor to that. So I'm really, really leery of pressing someone who's not truly clinically perfusion dependent.
So I would actually just agree with everything said, but maybe I can say something about the pathophysiology. I think that we've always looked at blood pressure reduction as something to do after the recanalization, but I think what is under-recognized is the recanalization itself determines the systemic blood pressure. So when patients actually have recanalization, the blood pressure will spontaneously reduce, and when they have re-occlusion, the blood pressure spontaneously increase. So patients who get thrombolysis have more fluctuation than placebo-treated patients in the NI-induced TPA trial. And then in terms of, let's say that, patient had a complete recanalization. So, I think there's going to be a difference in opinion. Some people, would say, like, I agree with what Alexander had said earlier, just keep the systolic blood pressure less than 180 millimeter of mercury. Some people would advocate for actually lowering it more aggressively. But I think one thing is that we assume that once recanalization is done, or the medium-sized artery recanalization done, tissue perfusion has been restored. And that is not always the case. There's no reflow phenomena of a secondary perfusion deficit because of plugging of the capillaries and the microvessels. And increasing blood pressure or lowering blood pressure perhaps does not modify that in any particular direction. And that's why the blood pressure reduction to different magnitude doesn't seem to have a big difference in patients after recanalization.
Great. And I'll begin with, I'm an emergency physician, and so assuming we're having to have this discussion on their way to the angio suite, I would say if the patient needs to be intubated, my first question is how do we make sure that gets done right? I probably would be very hesitant to lower the blood pressure because the intubation process and the meds we give may influence that. So focus really hard on that. I may not know what's the right blood pressure target, but I know hypoxia is bad. And so I would focus really hard on getting the intubation right, and what do we have to do to get that right?
And in terms of medications, do you have any choice in terms of what medications to use if you have to use an antihypertensive?
Well, I think what we have all said points to something that is short-acting, easy to control, things that you presented earlier, like the IV calcium channel blockers that are going to give us that quick control. However, if they get intubated and that pressure starts to go down, we can quickly take that off and they can rebound that pressure on their own without pressors and things like that.
So let me tell you what happened. This was the initial run of the DSA, and this was after first passed recanalization. And the patient stayed during the short procedure with systolics in the 160s, 180s. The procedure was done as we usually do under local anesthesia. There were no blood pressure lowering medications given, and immediately after reperfusion, the blood pressure spontaneously declined to the 140s, 150s, as you would expect somebody without history of hypertension and preserved autoregulation to happen following successful reperfusion. So moving forward, last question, what blood pressure parameters would you favor?
So I'm a little bit lucky in my institution because we currently are studying this. And one thing that we utilize is TCD in patients that have had both successful recanalization and no recanalization at all. And what we are finding is that exactly sort of like what we're saying, in patients that have had successful recanalization, we can be a little bit more aggressive with that blood pressure, and we're more comfortable with some of those lower targets that are interventionalists, like systolics of 160 or 140s, to prevent more shear stress on that endothelium. If a patient hasn't had that successful recanalization, or that successful recanalization, then that parameter is going to be much different. So in this patient who had probably a TICI 2C or 3, I would be a little bit more comfortable with that systolic 160 is probably where I like to live. But I'd love to look at the TCD.
I would say that, essentially in our institution, the systolic blood pressure will be lowered to less than 180 milliliter of mercury, so in which case that's already achieved. So no additional medication will be given. I think that, just following up on the point of transcranial Doppler ultrasound, we actually do perfusion scan after the thrombectomy to see if there's any residual perfusion deficits. But we haven't used it in any real treatment decision making for blood pressure, but we are collecting that information.
I'll defer on this one.
Okay. So essentially, everybody says Mayo is very expensive, but we just keep the blood pressure less than 180 without any studies. So the patient recovered well. She remained actually normotensive from their own words, and she was anticoagulated for presumed hypercoagulability related to the cancer, and she's now receiving treatment for her cancer, and hopefully she's going to do well. The MRI looked fine on the left. There was nothing on the right. There were small embolic lesions afterwards, probably because it was a proximal embolic source. And that's it.
Great, thank you. So next I'll do next case. There we go. There we go. So in this case, this is an 89-year-old male who presented with the acute onset of left face numbness and left arm numbness. That was it. So pretty small neurologic deficit here. Time of onset 1 hour ago, so this person is really very recently into whatever event is happening. Past medical history of atrial fibrillation, hypertension, and ischemic stroke. Is on apixaban, simvastatin, and metoprolol. And last dose of apixaban was about 6 hours ago. This patient arrives with a blood pressure of 200 over 100. And so I'll just actually move to in the sake of time, we'll move to the case for the discussion. And here was the initial non-contrast head CT, which showed a right thalamic hemorrhage. And I think the next slide will be, so the question is how to treat this. And I want to start with, this is an interesting question of, when this comes up, and I don't know if this happens with you guys, when somebody comes in with a small hemorrhage, people are usually like, oh, right, the small deficit, small hemorrhage, and everybody sort of relaxes and says, we don't need to rush on this one. And so, I don't know if this has happened with you guys, it happens with us a lot. Whereas if somebody has an enormous hemorrhage, everybody rushes to do things, even though I kind of worry in that patient, right, maybe nothing I do is going to change their outcome. Whereas this person, maybe there's a huge opportunity to change their outcome. This person is early in their course, and maybe has a high risk of expansion, and if there was something we could do, this is the person who's going to benefit from it. And if there's ever a time window on anybody, this person is within probably that time window to do something. So if there's something we can do to prevent this small bleed from becoming big, these first hours are the best opportunity for this person with minor deficits to have them just sort of stay minor. Minor, of course, to us, not to the patient. So maybe I'll go to our panelists. How should we? What's the goal blood pressure, and is there a speed at which we should get there?
See, Dr. Qureshi's talking now. Yes. So our guidelines would tell us, again, we're going to have that blood pressure range 130 to 150, target that initial, and based on all the evidence that was presented earlier, we want to do that quickly, but safely in a smooth, controlled method. So probably not things like bolus medications, if we need to treat medications where we're gonna have a lot of variability because we're only treating the peaks. We get to a valley and we treat the peak again. We want something that's gonna be a little bit more sustained, even if we just need just a very small amount of blood pressure control. In my clinical practice, I have a hard time just arbitrarily targeting a number because you have to look at that patient that's in front of you, especially in the emergency room where we may not know every single piece of history, renal artery stenosis, what else is going on in the lungs. So although I'm gonna try to target that guideline for the parameter, I'm also gonna see how that patient responds. And probably the number one thing I'm gonna do is make sure that they're in the emergency department room that has the stroke champion, stroke educated nurse. So that nurse understands why we're picking the blood pressures we're picking and how to achieve that in the most sustained way.
So one thing I want to add is that if you look at the hemorrhage volumes in today's world, most hemorrhages will be small hemorrhages. So it's just overrepresentation of small hemorrhages in the patients that we are seeing now. And then secondly, obviously, there is a representation of patients on anticoagulant-related intracerebral hemorrhages. So that is the changing demographics, because of a increased use of anticoagulation in older people, and also patients coming in early where the hemorrhage is actually small and hasn't had the opportunity to expand. But you said well that these patients are probably where you want to prevent secondary injury to the maximum. So I think that in terms of a blood pressure goal, the goal I think is keeping it between a value of 130 to 150 millimeter of mercury. I think the agent is very institution dependent because that's what we are working on finding in Clutch, that there's going to be institution that will be using clofazimine, and there's going to be institution that will be using nicardipine to achieve the same goals. Because what hasn't been shown is that getting to blood pressure reduction much faster without the fluctuation really actually truly benefits patient outcomes. So that remains to be proven. I think in terms of risk of treatment, we always talk about the risk to the brain, but I would actually argue that kidneys are also at risk. And I think there's considerable data that patients who come in with intracerebral hemorrhage getting intensive systolic blood pressure reduction, acute kidney injury is actually a real phenomena. These patients have chronic hypertensive renal disease, and actually the renal perfusion is pressure dependent, so as to aggressively lower blood pressure, the kidneys may actually be at risk.
I don't have much to add except that to all that was said. I mean, if you're going to use boluses, stacking boluses is what gets you into trouble. You stack boluses, and at the end, they catch up with you, and the blood pressure plummets, and that is when the damage occurs.
All right, fantastic. I'll skip the anticoagulation one, and I'll talk how was this treated. So this patient did get initial boluses of labetalol, which we would, darn it. I will say, at least in my shop, that's what the patient goes to CT, and that's what they bring with them, because do that, and then they'll get a bag of whatever after that. And the initial boluses didn't have any effect. And so the guy in the room was converted to IV clofazimine, and the blood pressure was lower. So the blood pressure ultimately was lowered to about 130 over 90 over about 2.5 hours. And this is just real life. There's a lot of data that real life takes even longer, even in the clinical trials, right? It takes a long time. These are clinical trials where the research team is really on top of it. So real life is worse. And so it just highlights an opportunity for all of us to push harder and push faster. And this patient did not have any expansion and had good clinical outcome. So I'll stop there, and we'll move to a question and answer session. We have some great questions, and hopefully we'll have time to get through some of them. Let's see. All right, so we have one question for either Dr. Robinson or Dr. Qureshi. Does the need for acute anticoagulation or infused antiplatelet medications change your blood pressure targets in ischemic stroke, given an increased risk for hemorrhagic transformation?
Well, as long as the blood pressure is below 180, I rarely change the parameter. I am there for all the endovascular cases, handling the case with the CRNA. And there are situations in which I get concerned, and there may be individual instances where I may be a little bit more aggressive. But in general, even patients that I have to use, let's say now we are using Gangrelor, and I have to then load with aspirin and Plavix. If the blood pressure wants to be in the 160s, 170s, I personally let it stay there.
I find the question fascinating because all the guidelines that were written was in a time frame where antiplatelet agents were supposed to be avoided in the first 24 hours. But as thrombectomy has evolved, stents are being placed, re-occlusion is being seen, so patients are getting intravenous or oral antiplatelet agents. And we don't really have enough information that now that you're seeing an increased number of patients getting, for example, Cangrelor or boluses of antiplatelet agents, whether our blood pressure goals should actually be changed or the same blood pressure goals are fine.
And I think one of the times that I get concerned and might adjust my blood pressure goals is if a patient has a large core infarct and maybe I'm starting IV heparin for an LV thrombus or something, 24 hours later. Those are the patients that I think I would be a little bit more aggressive on staying on the lower end, just because I am worried that that larger core is going to have that higher risk of hemorrhagic transformation.
And obviously, the more that you separate yourself from the time of occlusion, the more comfortable I get with lowering the blood pressure.
All right, and then interestingly, for the panel, this person adds that in these blood pressure trials, typically there's no mandate for for art-line blood pressures or non-invasive blood pressures, and that art-line blood pressures are often higher. Should there be different goals if you're measuring off an art line versus a cuff?
Oh my gosh, I have this conversation with people constantly, and I agree. It is so difficult. If we could put an art line in everyone, I would much prefer to follow an art line blood pressure. But the reality is we have to model our trials how we actually model our clinical practice. And in clinical practice, it's rare that I'm just going to be able to get an art line in someone unless they're with my fantastic neurocritical care team. And so we would need to establish first, what is that consistent difference? And if there is a significant consistent difference, then differentiate what those goals might be. But I don't think we know that. I don't think we have enough data to say these are the differences at this point.
Yeah, I think that this question arose when ATAC-1 and ATAC-2 were being designed, whether an arterial line should be mandated or not. And I think that the consensus at that point was a automated blood pressure cuff was giving information that was accurate enough that treatment can be titrated based on that. I think also the other thing is that the practicality, that getting an arterial line in most emergency department is going to be difficult. So basically the arterial line would not be placed till they got to the ICU. So that means the first few hours have already been delayed. So where the maximum benefit of blood pressure treatment and reduction are, that's already behind you once you get your arterial catheter in place and have that data available.
Great. And actually it leaks into one of these other questions, which is, do you have to start an art line if a patient is on nicardipine or clofidipine? No?
Absolutely not.
Absolutely
No. That's one of the benefits, because you're not automatically needing to be in an ICU with an art line. It allows that to be a little bit more generalized of a treatment throughout all of your institutional levels of care. Yes,
Sorry?
very much.
Could you say that one more time, Dr. Shutter?
So at my institution, if you have an A-line, or if you have a clofidipine drip or a nicardipine drip, if there's any titration going on, you have to be in an ICU.
Got it.
And I think that's generally I think that's generally sort of how I see practice, is if there have been more than 2 titrations in a certain amount of time. Yeah, so I think it just kind of is very dependent. Some places, the stroke unit is kind of like an ICU, so it really is institutionally dependent.
And I'll just say it out loud for the recording. At this institution, if somebody's on a nicardipine or a clofidipine drip with titrations, they have to be in an ICU for that event to occur. Great. Next, we have a question for Dr. Qureshi. If an ICH patient arrives with a systolic in the goal that's already within a goal of 130 to 150, and then drops their blood pressure below that goal, like below 130 or 120, do we initiate a pressor? Which Dr. Meyer already answered, or addressed. The question is for you, though.
So this was a question that also came in ATAC too, that if you are in the standard systolic blood pressure reduction group and your blood pressure spontaneously goes into the intensive systolic blood pressure reduction group, do you actually initiate a pressor to bring them back in the target therapeutic or the range that was specified by that arm? And in that trial, we basically simply said give them intravenous fluid, but no need for pressor. I think that it also brings a very interesting question that there is blood pressure reduction consequent to an antihypertensive agent, and there is spontaneous blood pressure reduction, and whether they truly have the same prognostic value or not.
Certainly, they most likely have a different pathophysiology.
Mm-hmm.
Great. All right. I'll do 2 more questions, and then we'll be done. First is, does TCD capture the, and this is for all the panel or anybody who wants to answer it, does TCD capture the absence of flow in smaller vessels in patients with no flow phenomenon?
It depends on how small a vessel you're talking about. We can probably go out to M2, so a medium vessel, but in the much smaller vessels, and especially in the very important microcirculation, like Dr. Qureshi was addressing earlier, no, you're not going to see that. You're really just going to see the large and the very proximal medium vessels in TCD.
Great. All right, and then I'll do the next question. The last question is, does the lowering of the blood pressure with clofidipine versus nicardipine, did that account for user error, titration fluctuations by the nurses, and this is also addressed as blood pressure versus art line readings? I don't know if there's any comment on that.
So I think this is a very important question that, there is data and there is processing of data. So you can get a lot of data, but the nursing staff may not be able to respond to that data. So, I think when we talked about it in our meetings that we said that, if any number of data that's actually less than 5 minutes, the blood pressure treatment would not be, it's very difficult to adjust blood pressure treatment. A nursing staff cannot be there every minute to keep altering the infusion for data that's coming in so fast. So as it stands, I think the biggest limitation on the titration is how fast you can process the data. So not, because you can get the data with an arterial line every second.
Yeah.
And also, what is safe? Is it safe to react to every single number, or you need to have a little bit of time to follow the trend?
All right, so we've run out of time, and I do want to make sure we finish appropriately on time. I'm going to say, but we'll have some last comments from Dr. Shutter, but I'll just begin with thanking the panel for their time and their discussion. Please, before you leave, fill out the survey so you can get your CME and so we can get your feedback.
If you heard me make an announcement earlier, you feel free to get up and leave, but if you are getting your lunch